welcome everybody. This is a follow-up to Pathogens and You COVID-19 discussion. It's part of a series that we've had in the microbiology department at the University of California, Irvine for many years, where we take a pathogen, a microbe in the news, talk about the clinical aspects and also the ongoing research. And obviously COVID-19 is the topic of the moment. I'm Ming Tan. I'm an infectious disease physician scientist in the microbiology department, also in the division of infectious diseases. I'm very pleased to be joined by Dr. Saahir Khan. He's an MD, PhD, infectious disease physician scientist. So I'll talk about the clinical aspects and the outbreak, and Dr. Khan will talk about a number of issues such as testing and treatment. As I said, we had the first talk about a month ago. A lot has happened since then. We've all been subject to the shelter-in-place lockdown, so it's affected every aspect of our lives. We've also learned some new things, particularly about transmission. We'll talk about other developments also, including things like testing. All right, and so this is an outline that we had last time, which hasn't really changed. This is a pandemic caused by a novel coronavirus, and it presents mainly as a pneumonia, but we're learning that many cases are mild or asymptomatic, and the spread is from person to person. And the reason we're having this pandemic is that there's no pre-existing immunity in the human population. We have some treatments that are being tested, but nothing definitive, and we don't have a vaccine. So that puts us in a tough spot. Now here's a timeline of the pandemic. So the first cases that we know of are from the very end of December in Wuhan, China. There's now some speculation that there might have been cases a little bit before that. And then spread outside the China, we know in the middle of January. Now, something new is we now know the first US death was February 6th in Santa Clara County, California. And so prior to that, we thought the first death was about 3 weeks after that in Washington State. And the interesting thing about this case in Santa Clara is that it was someone who had no known travel-related history or exposure. So this is, looks like it was a community case. What that says is that it's likely that COVID-19 was being spread, at least in California, several weeks before we knew it. So the first US cases date back to the middle of January, but they were all related to travel. And so now the indication is that the virus had actually been introduced into the US several weeks before we knew it and was circulating in the community without anyone knowing about it. We know that the outbreaks first went to Italy, Iran, and South Korea in March, but then spread around the world. By the end of March, we had more cases in this country than anywhere else in the world, and we still have been the epicenter with the most cases and deaths. April 2nd, when we had the first seminar in the series, there were 1 million cases worldwide. As we'll see, the number has skyrocketed since then. So Johns Hopkins has a very good interactive map, and this is from yesterday. We have now more than 3 million known cases in the world. There's going to be an issue about what is the actual number of total cases, because these are cases that are confirmed by testing. And the number of deaths in the world is now over 200,000. Again, there's a question as to what the actual death number is. If we look at worldwide deaths, you can see that we said that more than 200,000 deaths in the world, but we have more than 60,000 deaths in the United States. So we have a large number of deaths in this country. You can see other places, particularly in Europe, which have a lot of deaths. Some of the initial places where there were outbreaks, such as China and Iran, the total number of deaths is actually relatively small compared to what we've had. Now, it's not completely horrible in this country because we are a big country. So although we have a lot of deaths, it's because we have a big population. So if you look at the daily number of deaths, but now adjusted per capita, you can see that the US still has a lot of deaths, but not out of proportion to its size. So we have more than 1 million cases in the US now. The deaths are 60,000 and growing. To put that in perspective, that's more than the number of deaths each year from seasonal flu. It's also more deaths than in the entire Vietnam War. You can see a map of the US with the epicenters. And as we all know, the major focus in the country has been New York City, but the entire Northeast has had a lot of cases. There are outbreaks also in other cities, such as Chicago, Detroit, New Orleans. And on the West Coast, you can see we've had been lucky and we've actually had fewer cases. There are quite a few cases in LA, but compared to the rest of the country, the West Coast has actually done fairly well. And some of that may actually be because of the early response and the early shutdown in this part of the country. Focusing on California, this map on the left shows counties in California. The darker the color, the more cases. You can see that although there were early cases in Northern California, including Santa Clara County, the more cases are now in Southern California, and most of that is in LA. In Orange County, we have cases, but not as many as in LA. The good news, as you can see from the graph on the right, is that the number of new cases seems to be peaking. It certainly hasn't come down, but the curve, although the number of cases reported every day changes, we haven't seen a major surge that we feared. So we have almost 50,000 cases in California and almost 2,000 deaths, of which half of those deaths are in LA. Focusing a little bit more on our region, you can see again that most of the cases are in LA, and here in Orange County we have some cases. These are reported by city, so we have cases, but again the major focus in our area is north of us in LA. These are cases for Orange County. We have just over 2,000 cases. The graph shows the number of new cases reported every day. If you're like me, I'm eagerly looking at this every day, and sometimes we have numbers that seem quite low, and that's comforting, and then sometimes numbers which are quite high. So the daily changes may be related to testing and weekends, but we seem to have settled on approximately 60, 70 new cases a day. The major cities in Orange County also have the most cases. In Irvine here, we have 126 cases. Other big cities in the county also have cases in the hundreds. We have had 44 deaths in Orange County. Again, compared to the rest of the country, this is actually not a high number. I thought this was interesting. The Orange County Healthcare Agency, which is our public health department, releases daily statistics. And here they break down the number of cases by age. And so it's color-coded, but basically purple here would be kids under 18, and then increasing age until you get to dark blue, which is 85 plus. And so you can see that there are cases in young children and adults as well. So more than half the cases were in people under 55. Having said that, when we look at deaths, we can see that most of the deaths are in older individuals. So dark blue, 16% of the deaths in Orange County, and that's over 85. And light blue, 34, about a third of the deaths in people 75 to 84. So individuals over 75 make up half of the deaths in Orange County. This mirrors what we've seen worldwide, which is that with increasing age, there's a greater fatality rate. One of the issues when comparing numbers of cases is that it might also depend on how much testing is being done. And so it's actually good to look at how many people are hospitalized and also the number of deaths, although even deaths can be underreported. But you can see here the number of hospitalizations are in orange in Orange County and the deaths in blue, and you can see we're fairly stable here. So that's good news that the number is not increasing, but it also hasn't come down. And this is despite about 4 weeks of lockdown. These are how the COVID-19 presents. This slide hasn't changed. The main presentation would be fever, 80 to 90, and sometimes close to 100% in different studies. And then associated with that would be some respiratory symptoms, a dry cough, meaning that the person is not coughing anything up, and also dyspnea, which is difficulty breathing, and then some associated fatigue. There are additional signs and symptoms that have been reported. Some patients have gastrointestinal complaints. Interestingly, some patients have disorders of smell and taste. We don't know yet how common this is, but it's quite distinctive. And there have been complications such as cardiovascular, neurological complications. And then also some individuals have an intense inflammatory response. It's been called a cytokine storm, and this is associated with worse outcome. Now, in the 1 month since we had our first discussion of this, we've learned some new presentations. So there's a lot of interest so far in something called a coagulopathy, which is a coagulation abnormality or a clotting problem. And so we've seen that some COVID-19 patients have a propensity to form clots. This is something similar to what we see in sepsis patients who have something called disseminated intravascular coagulopathy. There's some distinctive things about the COVID-19 presentation. These patients don't present with a lot of bleeding, but they're at high risk for thromboembolism, formation of clots in veins, and this mainly shows up as pulmonary embolism, so clots to the lungs, which can be fatal. It's thought to be due to a host inflammatory response. These patients have worse prognosis. There's some questions about how to treat this. The patients get prophylaxis with low molecular weight heparin to prevent these clots. Some people are advocating full therapeutic anticoagulation, but this is not standard practice yet. But this is something seen in a number of COVID-19 patients and related to worse outcome. There was a group that proposed that COVID-19 be divided into different stages. This has not been widely accepted, but I thought it was helpful to look at this. So traditionally, we have classified the COVID-19 presentation as a mild infection, severe, or critical. Critical would be patients who go to the ICU, end up on a respirator. They have ARDS, which is acute respiratory distress syndrome. This is where there's damage to the lungs and patients are not able to oxygenate, and it's associated with very poor outcome. But, and we have numbers from China that about 80% cases were mild and only 5% were critical. But the table basically acknowledges that there are also additional stages. The interesting one being the asymptomatic stage. We'll talk more about this, but we don't know what percentage of individuals are asymptomatic, and it may appear to be a large number. And then this staging system also acknowledges that some patients recover, but also some patients die. Now, to give you a sense of the timeline of infection, the incubation period, the time between exposure and developing symptoms, is usually 4 to 5 days, although it can be as much as 2 weeks. And the interesting presentation is that patients really get worse after the first week, if they're going to get worse. And so basically, patients may have fever, they may feel tired, but shortness of breath, if it occurs, tends to occur at the beginning of the second week, so about 7 or 8 days. And these patients rapidly get worse and have ARDS, that acute respiratory distress syndrome, and require assisted ventilation very shortly after that. So within 8 days of symptom onset. That's when these sick patients get hospitalized. On average, patients who survive will stay in hospital for 10 days. But some patients don't recover, and they die on average about 18 days after symptom onset. For patients who have mild infection, they can recover after 2 weeks. Severe cases can go on for 3 to 6 weeks. Now, we're starting to get some information to indicate that the number of COVID-19 infections may be much higher than what we know from testing. And the way this is being done is with a serologic test, meaning they take some blood from the individual and they look for antibodies against the virus, which is the SARS-CoV-2 virus. And that's to indicate the patient's been exposed and has mounted an immune response. And so this is now being done in different parts of the country. In our area, it was done in LA County, and they found that 2.8 to 5.6. So what they do is they test a group of people, but then extrapolate from there to the community. And so they tested about 1,000 people, and they then extrapolated from there to say that 2.8 to 5.6% of LA County has been exposed and infected, and that's 28 to 55 times the number of confirmed cases. So that indicates that, one, the virus has been much more prevalent than we imagined, and also that it indicates that a lot of these people then had mild or no symptoms, so they would be in the asymptomatic group. In Northern California, it's been done in Santa Clara County, and they also found that the estimated prevalence rate was 2.5 to 4.2%, about 50 to 85 times the number of confirmed cases. So you can see that the estimated number of cases is many times what we know from testing. This has also been done in Miami and New York State. In each case, they've seen, again, many more cases than confirmed. In New York State, the prevalence is estimated at almost 14%, and in fact, 21% in New York City metropolitan area. There's also an issue with the number of deaths. So we have numbers for deaths attributed to COVID-19, but there's data now coming in that the number of deaths may be much higher. So on this graph, you can see the seasonal average of deaths in the US, which is the line, and the dotted line. And then you can see that the actual number of deaths in late March and April has really spiked. And the crosshatched ones are the ones that we know are due to COVID-19. But there are also these cases here that excess deaths, but not attributed to COVID-19. But the suggestion there is that they're also due to COVID-19. So you could call these excess deaths. They're basically twice as many deaths as we know from COVID-19. So it may be that the number of deaths from COVID-19 may be twice as many as we know. And this has been also looked at in individual cities and in states, and it holds true. Let's talk about transmission. We've learned a lot about transmission in the past month. So the transmission is human to human. Although the virus is thought to originally have been an animal virus, maybe from a bat, the transmission now is just human to human. And it's a respiratory infection. The vehicle of transmission are respiratory droplets. The viruses are in these droplets. They're produced by an infected individual who is coughing, sneezing, or talking. And then what happens is a second individual encounters these respiratory droplets. So the main route is this direct spread from one individual to another. And the viruses are inhaled or they land on the mouth, nose, or eyes. It's also possible to have direct spread via the hands. And then, so if respiratory droplets land on your hands, and then you touch your face. And the greatest exposure has been 6 feet, although this is mainly work done from influenza virus, so we're extrapolating from there to coronavirus. Now, less commonly would be spread through surfaces or objects which are contaminated with the virus. So in this case, the surfaces are contaminated by the infected individual, by their respiratory droplets or hands. And then a second individual touches those surfaces and then touches their face. There's been a lot of concern about this. This is why you see people being concerned about getting close to somebody or touching anything that's been touched by another person. We have to put this in perspective. For most casual interactions, you're not going to acquire COVID-19 this way. So if someone briefly touches something and then you touch it, the risk is low. The risk is highest when there's heavy virus contamination of the object. And that is going to be in two situations. One, in the household of the infected individual, or in the hospital. So again, casual contact, if you encounter someone and you just pass them on the street, again, the risk is low. It's basically if you're within 6 feet, facing somebody, engaging in conversation for a long time, or if there's heavy virus contamination of surfaces and environments. So transmission is most likely in, as we said, in two situations. One is in households. There's a lot of data about this. So 50% of cases in Beijing, the first few cases were in household clusters. And then in the US, we've done some contact tracing where they've looked at contacts of cases, and they saw that the secondary attack rate, meaning what percentage of individuals exposed to the index case acquired the infection, and that secondary attack rate is much higher in household contexts compared to other contexts. And this makes a lot of sense. Again, we said there's a lot of virus contamination in the household of an infected individual, and other people in the household are exposed over a long period of time to the virus. There's also high exposure in hospitals. There have been studies looking at contamination of environmental surfaces in hospital rooms of infected patients, and they basically swab all kinds of surfaces in the room, and they can find it everywhere. And that just speaks to how much virus is being produced by these infected patients. Now, an important caveat here is that these studies have looked at viral RNA. This is an RNA virus. It's genetic material as RNA, not DNA. And we have ways to detect the RNA, and Dr. Khan is going to talk to us about a test, a PCR-based test to look for viral RNA. So these studies check for viral RNA, and that indicates that there's viral material there, but it doesn't tell us if this is viable virus that can actually cause an infection. And so hospitals have instituted cleaning procedures to decontaminate environmental surfaces, and the good news is that the SARS-CoV-2 virus is easily disinfected, inactivated by disinfectants. This received some wide exposure recently, but agents like ethanol, hydrogen peroxide, and bleach can actually rapidly kill the virus within a minute. And so hospitals now have enhanced cleaning procedures for rooms of infected patients. We now know quite a bit about the time course at which an infected patient sheds the virus. They've looked at transmission pairs in China. So this would be two individuals where one person acquired the infection from another person. The advantage of these studies is you can actually then study the secondary case before they have symptoms. So the virus is detected 2.5 days before that second case had symptoms, and the highest viral load was half a day before symptom onset. So this is very useful information. So what this tells us here is that someone can be shedding virus for several days before they develop symptoms. There was also a study in Germany, although just a few patients, but they showed that the virus levels were highest during the first week of symptoms. And then after that, in the second week, they couldn't isolate any virus, although they could still detect the viral RNA. And the point here is that you can detect viral RNA, but that is not equivalent to infectious virus. And they looked at virus in other samples besides respiratory samples. They can detect viral RNA, but not the virus in stool. We don't think this is an important means of transmission. And they did not detect viral RNA or virus in blood or urine. We know that now that other data showing that individuals can shed virus before they have symptoms, we now call this the presymptomatic period. And so individuals can shed virus for 1 to 6 days before they have symptoms. We know this from particular groups who were in enclosed space. So one was the Diamond Princess cruise ship, and also a nursing facility in Washington State. And in these cases, about 50% of individuals had a positive test without symptoms at the time, although most developed symptoms later. Now, the important question, though, is if people are shedding virus before they have symptoms, can they transmit the infection to someone else? So can someone without symptoms transmit to a new person? And the best data we have is from Singapore. Here, they found that 6.4% of their cases were due to spread from someone in the presymptomatic phase. Now, the good news here is it says that most of the cases, the large majority, over 90% of the cases, were spread from people with symptoms. Because the concern is if someone doesn't have symptoms, then how do you know that they can spread it to you? But in this case, 6.4% of the cases were documented to be in individuals who didn't have symptoms yet, and we're going to develop symptoms 1 to 3 days later. We know that SARS-CoV-2 is shed in the upper respiratory tract even during this presymptomatic period, and this is very different from the original SARS virus, where the shedding is much later and is from the lower respiratory tract. Now, the big question is, what about patients who are asymptomatic? asymptomatic, not just pre-symptomatic, but never have symptoms. As we said, there's growing body evidence that some people have no symptoms even though they're infected. And the answer is we don't know that. So the patient who has mild or infection without symptoms, we don't know how infectious they are. We do know with influenza that if a patient is infected but asymptomatic, then there's a lower risk of transmission. But again, this is a different virus. We don't know how it applies to COVID-19. So this is an unanswered question. So if we have 10, 20, 50 times the number of people who are infected but don't have symptoms, this is a reservoir, but are they spreading the infection? And we still don't know the answer about how much they're contributing to spread. Another question that people have is there transmission by airborne droplets? So I mentioned that the spread is by respiratory droplets. Those are relatively large droplets, but we're concerned about small droplets that can linger in the air for hours. And diseases spread that way are very contagious. So if we look at the numbers, the suggestion is that COVID-19 is not spread by airborne droplets. So in the infectious disease epidemiology world, we refer to something as the basic reproduction number. That's the number of new cases for each original case. And that number for COVID-19 is about 2.6, meaning that from one person, it can spread to 2.6 new people. Now, true airborne diseases such as chickenpox and measles have a much larger number, so in the 12 to 18 range, indicating that there are many more secondary cases because, again, it's spread by these airborne droplets. So the numbers so far don't suggest that COVID-19 is spread by airborne droplets. But we do know that you can form airborne droplets containing virus, especially in the hospital with clinical intervention. So you may have seen the term aerosolization, that is describing the process of forming these small airborne droplets. And a number of things we do in the hospital, such as intubating the patient, performing bronchoscopy, these generate aerosols. But again, what I want to reassure people is these are unusual interventions occurring in the hospital. Hospital people need to then wear an N95 mask to protect themselves. But in normal daily life, you won't encounter these things. So there doesn't seem to be any indication for using an N95 mask outside the hospital. Now, you may have seen there have been some studies where they've talked about how the SARS-CoV-2 virus can remain viable in aerosols. And the thing to know is that the most cited study from New England Journal of Medicine were where they produced aerosols in a highly artificial manner. And then they were able to detect the virus in the air for 3 hours, and they also detected on surfaces for several days. Now, the strength of the study is they actually measured the viable virus, so not just the viral RNA, but the limitation is that this is a highly artificial way of generating aerosol. So again, more akin to what might be happening in the hospital, but not in real life with an infected patient. I'm going to go over a number of scenarios where we've learned about transmission. So one of them was on a cruise ship, the Diamond Princess. And basically, we know that, interestingly, so 712 out of 3,700 passengers were infected. But among the passengers, all the transmission occurred before they were locked down in their cabins. And then once they were restricted to their cabin, the only new transmission occurred within people in the same cabin. So again, reinforcing the idea that most of the spread is among in a household. Once people didn't gather in large public places, there was no transmission on the passengers. In contrast with the crew, they were not quarantined, and there was continued transmission among the crew. And we know that the ship's air conditioning system does not seem to have been involved. If it were, then we would have much more spread among the passengers. We've also learned about transmission in the hospital. So there's a case where a patient had unsuspected COVID-19. This was in mid-February, early on, when we didn't know there were many cases in the US. And so this patient was in the hospital, but there were no protective measures for the hospital staff. So no so-called PPE, personal protective equipment. So this patient had a number of procedures done that can generate the aerosols. And yet, having said that, only 3 of 121 exposed healthcare workers developed COVID-19. And so what this tells us is even in this situation where we had a COVID-19 patient, there were aerosol generating procedures in the hospital, more than 100 healthcare workers were exposed and weren't protected, and we only had 3 cases. So it speaks to the fact that COVID-19 does not spread like wildfire to everybody, even when exposed. It also argues against airborne transmission. Here's an interesting case where there was transmission in a restaurant in China. And so this is a diagram showing tables in a restaurant, and these are individuals seated around the table. And the index case here is an A1, who is someone who came from Wuhan to Guangzhou, where the restaurant was. And at the time she was having this meal, she was not symptomatic, but she developed symptoms later that day. And so the red circles indicate people who got infected. So people, her family members around the table got infected. Maybe that's not a surprise. The interesting thing is people at neighboring tables also got infected. So patrons here at this table and this table. Now, we know that there was an air conditioning system and it was blowing air in this direction. So you can see how individuals in table B could be infected by air blown from table A to B. We don't know why individuals in table C got infected. The speculation is that the air from the air conditioner went in this direction, bounced off the wall, and then reached them. The interesting thing is that other customers in the same restaurant also close by were not infected. And that suggests that it's the respiratory droplets being blown in a certain direction by the air conditioner and not airborne all over the restaurant, which would also have infected individuals at tables E and F. And none of the staff got infected as well. So I think this suggests that it's really the respiratory droplets, but they can be spread in a certain direction by things like an air conditioner. There was a famous outbreak at a choir practice near Seattle. And so there were 60 choir members. They attended practice in mid-March. At that time, we knew about social distancing, so they were very diligent about practicing social distancing. But 45 out of 60 of the choir members developed symptoms, and 28 tested positive, and unfortunately 2 of them died. Both of those were in their 80s. No one was sick at the practice, so it was quite a surprise that so many individuals became infected at this choir practice. Now, the interesting thing is that it turns out there's been some data showing that production of respiratory droplets, respiratory particles, increases the voice loudness. So this is a study showing that if you look, the y-axis shows the number of particles. There are many more particles produced with speech compared to just breathing. And the louder the speech, here it goes from quiet to intermediate loud. The louder the speech, the more droplets being produced. And so you can imagine when singing, if anything, it's loud, you're trying to project the voice. It's likely that those individuals were producing lots of particles, which may suggest why there were so many people who were infected. It's also thought that the particles are being generated in the larynx, not just the lungs. There have been some reports of COVID-19 in animals, particularly cats. You've heard about it with tigers at the Bronx Zoo, also domestic cats. It looks like cats can have clinical disease, can actually spread it to other cats. Dogs can get infected but don't appear to have symptoms. But there's no reports of any spread from a domestic animal to humans. So the animals are acquiring from humans but not spreading back to humans. Although the CDC is now advising that you keep your cats indoors and you walk your dogs on the leash. I'm going to finish up with the issue of seasonal spread. And so these are other coronaviruses that cause the common cold, but they have a marked seasonal spread, mainly December through March and not the rest of the year. We don't know yet for COVID-19, but there's hope that it will also have seasonal spread. Basically, it's thought that the main reason why there's spread in the wintertime but not the summer is that in the summer it's warmer and there may be less humidity. No, sorry, mainly the summer months may be warmer and more UV light. So last slide here is how to manage the pandemic. And we go back to the pandemic of influenza in 1918. So at the time, there was no test, no treatment, and no vaccine. Now we have testing, but we still don't have good treatment or vaccine. Dr. Khan will talk about these two issues. So this pandemic was managed with social distancing. About a third of the world's population was infected, and there were 50 million deaths over 3 waves over a year. And most of the deaths occurred in the second wave in the fall after the first outbreak in the spring of 1918. So this was managed with social distancing, and basically the outbreak settled into annual outbreaks with lower death rate. Now this is a different virus, we don't know what to expect here, but all of us are wondering, where is this pandemic going to go? And a lot of it depends on whether we can intervene with more than social distancing. Will we have treatment? Will we have a vaccine? Will we have testing? Will there be immunity when people have been exposed? So Dr. Khan's going to be talking about those issues. All right, thanks. So I'll pass it on to Dr. Khan.
All right, thanks, Dr. Tan.
Saahir, can I just say something before you start? If people have questions, they should type them into the chat, and I will ask them at the end.
Okay, great, thank you. Let me just open up. Everyone can hear me okay? Okay. All right, so COVID-19 treatment and testing is what I'll focus on here. And so just as a little bit of background, and I know Ming went over a lot of this already, but just to kind of reorient us. So COVID-19 disease, it's caused by the SARS-CoV-2 beta coronavirus. And then this is closely related to bat coronaviruses, as well as SARS, the original SARS, MERS, other coronaviruses that cause the common cold, like HKU1 and OC43, and a little more distantly related to a couple others that cause the common cold, NL63 and 229E. And so the reason that this was able to infect humans is that the mutation on the receptor binding domain of the spike protein it allows it to bind to the ACE2 receptor on the human respiratory tract epithelial cells. And the mortality is likely somewhere between seasonal flu and a pandemic flu, higher in elderly and medical comorbidities. Contagiousness is pretty similar to the common cold. And so this is just, on the left is just shown sort of the different genes of the virus and the structure of the virus, as well as how the virus binds to the receptor on the lung epithelial cell. And on the right is shown kind of some of the cases of the virus and how they relate to bat coronaviruses, SARS and MERS, sort of other coronaviruses. And this is how we think that it came from bats. I'll particularly point out these orange proteins on the surface of the virus are the spike protein. That's one of the major determinants of immunity and antibodies to the virus. And this is actually what binds to the receptor in the human lung epithelial cells. And so, you know, the death rate, and again, there's been a lot of data on this, but we know that elderly people do worse with COVID-19. We know that cardiovascular and pulmonary medical conditions do worse with COVID-19. You know, a lot of people have asked about cancer. Recently, it came out that the increased risk in cancer seems to be mostly restricted to lung cancers and cancers with lung involvement. So that, you know, that it goes with what we know that pulmonary diseases in general are higher risk. Interestingly, you know, we don't find so far that immunosuppression seems to be a major risk factor, because part of the pathology of this disease is that the immune system overreacting is sort of what gives you a lot of the severe manifestations. And males seem to be more susceptible than females overall. And there's a thought that initially that's partly due to smoking, which is a risk factor, but it appears to be found in a lot of different studies now. And so I think there is some male predisposition. So you know, one thing I'll say, and I'll talk about this a little bit in the subsequent slide, but, you know, the mortality that we see is very dependent on who we test. And so we're not testing the general population, or at least until recently, we weren't testing the general population or minimally symptomatic people. We were testing the people who are symptomatic, who are, more likely to have severe disease. So our mortality rates were probably higher than what the actual mortality rate is. And places that do more testing find lower mortality rates. And then, the bottom right is just talking about what I mentioned, how the immune system overreaction to the virus is a large part of the disease process. And this just shows that in patients with severe disease, a lot of these markers of inflammation and immune reactivity are higher. And so this graph here, it shows where the virus ranks. On the vertical axis is mortality rate, and on the horizontal axis is contagiousness, as measured by that R naught number that Dr. Tan mentioned, which is the number of people that can get infected with the virus. And now where I put it here is based on serology studies that I think Dr. Tan mentioned some of them. I'll talk about them in a bit as well. We're finding that a lot more people are infected with COVID-19 than our case numbers would indicate, or have been infected with COVID-19 than our case numbers would indicate. So, the true mortality rate probably falls somewhere in this region. And similarly, the contagiousness, this R naught, the number of people that can get infected with each case, this is actually going down as a result of social distancing. So, we're having some success there in terms of the virus is spreading less rapidly as a result of social distancing. So now, this is sort of in this range, similar to the common cold, more contagious and more deadly than the flu still. But I think it's sort of in this range. And if you look at something like the Spanish flu from 1918, granted, we didn't have antibiotics then, we didn't have vaccine, we didn't have a lot of things then, but that was actually probably more deadly than this will end up being. So the clinical course, there's an initial phase where you have virus, and then for patients who develop severe disease, they develop an inflammatory reaction that sort of overwhelms the system and leads to a lot of the severe manifestations. And so in the initial viremic phase, this is where you get mild constitutional symptoms, a fever, cough, headache. Some people get GI symptoms. There are some labs associated with this. Some markers of a particular type of white blood cell is low. You get some increase in some inflammatory markers. But at symptom day 5 to 10, and I think Dr. Tan mentioned, day 7 and 8 is sort of a point which a lot of patients decompensate. And so this is where you develop shortness of breath and hypoxia in a subset of people who go on to develop severe disease. And the chest imaging looks abnormal. There's these bilateral, what we call ground glass opacities. There's increases in inflammatory markers and in liver enzymes. And then, the patients that go on to develop critical disease end up in what we call acute respiratory distress syndrome, where they end up needing mechanical ventilation. Some of them develop cardiac failure as well. And there are massive increases in the inflammatory markers here in this phase. And so this, and this phase can last a long time. The average amount of time that the patients who do recover are on a ventilator is around 2 weeks. And so, I'm going to talk a little bit now about some of the antiviral agents, just quickly to run through. So you may have heard remdesivir. Some interesting data came out yesterday from a US trial of remdesivir. Actually, UCI is one of the sites for this trial. And this showed a trend towards improved mortality. So they did an interim analysis of this trial based on the first, I believe, 100 or so patients that were enrolled. And this analysis showed there was what looked like a decrease in mortality, at least a trend towards a decrease in mortality, although it wasn't quite significant yet because this was only a partial result of the trial in the patients that had been enrolled so far. There was also a decrease in recovery time, 11 days versus like 15 or 16 days for the patients who didn't get the drug. Now, there was a trial in China recently that was leaked that showed no benefits. So this data is a lot more promising on remdesivir. In my opinion, this trial is a lot more, this is called the COVID-19 adaptive clinical trial. It's a lot more well-designed and a lot more robust than the one in China that showed no benefit. So I'm very optimistic on this drug. However, this is not a cure by any means. This, you know, I would think of this as similarly to Tamiflu. It may be a little bit better than Tamiflu, but, you know, Tamiflu we give to people with severe influenza, and it has, you know, more of an impact in actually preventing people from getting severe disease than it does in necessarily treating severe disease. But, you know, it works, but it's not a cure. And similarly to this, you know, mortality going from 11.6 to 8%, like we get very excited about that. But, you know, that's still 8% mortality. So it's a modest benefit, but it's not a cure. And now protease inhibitors, these are some of the HIV drugs that were tried. There was a large clinical trial that didn't show benefit. Again, there seemed to be a sort of a trend towards benefit, but it wasn't statistically significant. So most people have moved away from using this drug. Hydroxychloroquine, you know, there was never any good data for this. It was all in vitro data, which is in the lab. Every clinical study initially that was on this was just a few patients, uncontrolled. And I think there was a lot of unfounded enthusiasm for this drug. And we now have found in a large retrospective study from the VA that actually patients who get hydroxychloroquine tended to do worse in that study. Like more of them died than the patients who didn't get this drug. And now, you know, people have some criticism. This was a retrospective study that they tried to control for risk factors of severity, but, you know, controlling for those is not always perfect. But anyway, I think most people are moving away from using this drug now. And, you know, I don't think you're going to see this as part of the treatment course going forward. Also, there was this combination with azithromycin. This was based on sort of one flawed study out of France that, you know, but unfortunately, these two drugs together have additive toxicity to the heart, causing arrhythmias. And so I think almost every society now argues against using this combination, hydroxychloroquine and azithromycin. So, you know, as I mentioned, this overall antiviral treatments for respiratory viral diseases, there really haven't been a lot of success with these antiviral treatments. And part of the reason is that the pathogenesis is more that your immune system overreacts to the virus rather than that the virus itself is directly causing damage. And so, you know, I mean, things like Tamiflu for influenza is the best known one. It has some effectiveness, but it's not a cure. And similarly, I think remdesivir, our most promising drug, you know, will have a modest benefit, but I don't think it's going to be a full cure. There are, you know, I mentioned the role of the inflammatory and immune system in causing a lot of the manifestations of this this disease. And so a lot of people are trying medications that act on the immune system and try to tamp down that inflammatory response to the virus. And so there are these drugs that block IL-6, which is a cytokine in your body that leads to inflammation. And these, you know, there have been some uncontrolled data that have been promising for tocilizumab, which actually we do use in the hospital here for very severe patients. The clinical trials on these drugs are still pending. Similarly, there's drugs that inhibit this JAK-STAT pathway, which is another pathway that leads to inflammation. And these drugs, you know, very little data is out on them. Clinical trials are ongoing. And then there's corticosteroids, which also tamp down the inflammatory response. These initially were sort of people argued against using these because in influenza, they actually increase mortality. So there was a lot of hesitancy to use these. The one situation in which they have been used somewhat is patients with this acute respiratory distress syndrome who have very critical disease. Because of this one uncontrolled study in China found some benefit in this subgroup of patients. And these are patients that there's some debate in general as to whether to treat with a steroid for other causes of acute respiratory distress syndrome. So the recommendations in this subgroup are mixed, but otherwise it's not something, because of this mortality with influenza, it's not something that's being used outside of this one particular subgroup. So I'm going to mention some molecular tests for COVID-19, and I guess we're going to get to the questions at the end. But you know, the principle of this is we try to detect the virus that's actively in the nose or the throat by performing a PCR reaction, which detects the genetic sequences of the virus in your nose and throat. And this is used for diagnosing active infection where you have shedding of the virus. Now, some of the limitations here are the sensitivity is limited for these tests to about 60 to 80% for two reasons. One is that you need to get a good sample. And if anybody's ever gotten a nasopharyngeal swab, it hurts and you have to get deeply in there. And I think a lot of times you don't get as deep as you need to. And the other thing is that you need a certain amount of the viral genetic material in order to for this test to be positive. And different PCR tests have different, what we call limit of detection. Usually the more rapid the test is, the more virus RNA that you need in order to have a positive test. And so, you know, because of these limited sensitivity, if the suspicion is high, we need to do multiple tests over time. You know, one test will not rule it out. If the suspicion is low and you have another good cause for the patient's symptoms, and you know, then maybe one test would be okay. But for if you are truly suspicious of COVID-19, you need to do more than one. I would also say that you know, this test can remain positive longer than the virus is contagious. So what I mean by that is, you can have genetic material of the virus in your nose or throat, even if the virus is not actively replicating, and even if you're not shedding live virus. And, you know, so a lot of people have run into problems in trying to use this as a test of cure to say that, oh, we're going to isolate you until your PCR test is negative because, you know, of this likely dead virus that is detected by this test for sometimes up to weeks. And so, you know, that's a problem people are dealing with. I think personally that, you know, we should rely on what limited studies we have that actually look at how long people shed actual live virus that is contagious to others, rather than relying on some of the, you know, PCR as a test of cure, because then you end up, some of these patients can shed this genetic material for weeks, but they're very unlikely to be infectious for that period. So I'll talk a little bit about serology tests. So these serology tests detect antibodies produced by the patient in response to SARS-CoV infection from blood. And so there's antibodies to diagnose recent infection, IgM or IgA, or past infection, IgG. And you know, this is used to find out if someone in an ideal situation to determine if someone has already been infected with COVID-19 at some point in the past. Even these early antibodies that diagnose recent infection, they are not detected until the second week of illness usually. And by that point, the patients who will have developed severe disease, you know, have already decompensated and are in the hospital. So it's not really that useful because, you know, by the time it's positive, if the patient's already in the ICU and, you know, you're already putting them on mechanical ventilation, it's likely you've already gotten a molecular test that's going to be positive. So what it's really more useful for is patients who have had COVID-19 in the past. Even that, there are some issues. You know, there are over 100 serology tests out there. Only 4 of them have even undergone emergency use authorization by the FDA. And just as an example, you know, there's one from a company called Premier Biotech, and this was used in the serology study in Santa Clara County. And the company claimed a sensitivity of 90 to 95%, and they independently tested it, and sensitivity was like 66%. So, and that has been found for a lot of these tests, that when we try to independently validate, because the company has presented data on only 10, 20 patients, oftentimes the performance of the test is lower when upon independent validation, because these aren't really going through much regulatory review. Specificity is, maybe you're in the 95% range for a lot of these. There's some level of cross-reactivity with common cold coronaviruses, and I do research in this area, and that amount of cross-reactivity is low, but the problem is, even if it's 95% specific, if you have a population where your prevalence of disease is less than 5%, which is a lot of the population. I mean, that's California right now is probably in that range, maybe a little bit higher. But that if you have that situation, half of your positives are going to be false positives. So even a 95% specificity is problematic in a low prevalence setting. It may be okay for a place like New York, which has higher disease prevalence, but it's a limitation. And so the biggest limitation of these tests is that the correlation of antibodies with immunity is unknown. So I'm going to talk about that in a little bit here. So what we know about immunity to human coronaviruses is fairly limited, because these viruses that cause the common cold haven't really been a focus of research as much as something like influenza, which kills 50,000 people a year in the US. So there's some older studies on experimental challenge, and I think Dr. Tan brought up some of these, but one of these common cold coronaviruses, 229E, there were 2 different studies on experimental challenge in volunteers. And one looked at sort of antibody titer and reinfection risk over time, and they found that if you had lower antibodies to begin with, you're more high risk of infection. And then if even the patients who developed infection the first time, many of them developed infection 1 year later, even though they still had some antibody titers, but those were milder infections. So they had some partial immunity. Another study found that, patients were able to be reinfected with virus strains that were genetically different. Even though they were from the same virus, they were somewhat genetically different, but they weren't able to be reinfected with the genetically identical virus. There's what we know from SARS is that these IgG antibodies, persist for an average of 3 years, but levels decline to 50% by 2 years. But this is actually very variable person to person. And then an observational study in Africa, looking at coronaviruses over time that cause common cold, did find a subset of reinfections. So, these range from anywhere from 4 to 25%, depending on the type of virus. And these were over a short interval time, ranging from like 47 to 98 days. So on the order of months. So a subset of people appeared to be able to be reinfected. Now the sequencing that they did was not the most robust sequencing of the viruses. So we don't know if these viruses were completely genetically identical. The study said that they were genetically similar, but it may be that the viruses they got reinfected with were somewhat genetically different, or it may be that a subset of people just don't develop effective immunity, a small subset of people, and those people can be reinfected. So I'm going to talk a little bit about herd immunity, because something you've heard a lot in the news. So herd immunity occurs when enough people are infected that the virus has trouble finding a susceptible host. And this can be calculated based on that R0 value we mentioned. It's probably about 50 to 60% for COVID-19. However, the problem is this is not like measles where you get it once, or it may not be like measles where you get it once and there's absolute immunity. Something like that, this herd immunity number is a lot more relevant. Here, if there's partial immunity, it's unclear. There is a population benefit, definitely, that if a lot of people have COVID-19 and have partial immunity, you're not going to get as severe disease. You're not going to get as many people who get the disease. But the number for this virus is probably 50-60% where we start to get to herd immunity. And currently, the seroprevalence estimates in the studies that have been done vary from, about 2.5 to 4.2% in Santa Clara, up to 13% in actually New York State. Actually, New York City itself, I believe, was a little bit higher, like 20%. And so even the places like New York that are the most affected, they haven't reached this number. Nowhere in the world, as far as I know, has reached that number. Maybe Wuhan, actually, that may be the only place. But, serology studies to date are limited by the fact that many of these tests are unvalidated or poorly validated. Sampling methodology in many of these studies may bias towards people more likely to have had infection. There was some criticism of Santa Clara study that they used, I think, Facebook groups to recruit people. So, the sampling is really important to make sure you don't get people who have some reason to be concerned that they have the virus or may have had the virus. You really want to get a good random sample of the population. And then these are small studies. I mean, these are studies of thousands of people, but the general population, like the study in New York was 3,000 people, and New York has, I believe, like 7 million or so people in New York City. So herd immunity is unlikely to be achieved in the near future because we're actually past our peak of infections based on the epidemiological curve in many places in the US. Now, we may have a second peak as we relax social distancing in many places. But in order to get to this herd immunity, one of two things are going to have to happen, or one of three things. Either the virus persists to spread over the summer, we develop a second epidemic in the fall, or we develop a vaccine. And so I'll just briefly finish, or I have a couple slides. So on vaccines specifically, there's there's different types of vaccines, but only these 6 are actually in clinical trials right now. And some of these are based on DNA or RNA vaccine. Now, those have not really been successful for other diseases in general. These inactivated vaccines are more of a traditional approach. And these viral vector vaccines, this is where you take genes from the SARS-CoV-2 virus and put them into a different virus that's not, doesn't cause disease. And so, these 3 approaches are all being used, and there's actually 70 other candidates in preclinical development. So we're working hard on this, but to get through clinical trials for a vaccine will probably require at least a year, just based on, even if everything goes as rapidly as possible. By the time it's available to the general public, it'll probably be a year. And so my last slide is just, I was asked to talk a little bit about this staged reopening. So Governor Newsom announced this earlier this week. And so currently we're in the shelter in place. We want to see a 2-week decrease in case numbers and increase in our capacity in hospitals and testing before we kind of open low risk workplaces. That's probably a couple weeks to a few weeks away. High risk workplaces are places where people have personal contact, like gyms, salons, potentially churches. And this could be months away because we really need to get better testing and better contact tracing capacity where I can actually trace cases in the community. And stage 4 is like sporting events, concerts. That probably requires either a vaccine or a really, really good therapeutic or herd immunity. So that's where we're at. And I guess if we have time, I can answer some of I see the chat has a lot of questions in it. So let me stop sharing and turn it over to.
Okay, thanks so much. I'm going to read the questions from the chat.
So this is Dr. Michael McClellan. He's been the chat moderator for the talk. So go ahead, Michael.
Okay, so we got a flood of questions near the end. So I'm going to read them backwards, but basically. So Dr. Gutman has asked, is the suggestion that the Oxford vaccine might possibly be available by September a fiction? And what's their technology?
Okay, so I can answer that. This vaccine is here. Let me go back to my slide. This vaccine is the, where is it here? Oh yeah, University of Oxford. It's a non-replicating viral vector vaccine. Now, I think to get clinical trials done by September is especially given the fact that we're actually not, we think that there will be a sort of pause not a complete pause, but we think the number of cases will be low over the summer. I don't see how you can get a large scale, because these vaccine clinical trials not everybody's going to get the disease. So it requires recruiting a large number of people. So I don't see how you can get a phase 3 clinical trial of a vaccine done by September. It just doesn't seem feasible to me. Maybe the vaccine could be available, like clinical trials could be open by September, but I don't think this vaccine will be approved and on the market by then.
So the New York Times had an article looking at the timeline for vaccines, and they talk about various assumptions. But the bottom line is normal vaccine development takes years or decades. So even a year would be extraordinary.
Another question is, can you comment on Sweden's alternative policies of dealing with the virus, which keeps kids in schools, restaurants open, and voluntary social distancing? And if I can interject there, and compare them to the rates in Norway and Finland, which are adjacent to Sweden.
Yeah. I mean, Sweden has an approach where they want to focus on high-risk individuals. So they want to basically say, we think that the severe cases are mostly in people who are older or have medical comorbidities. So those people we're really going to focus on. We're going to say, okay, if you are older or you have medical comorbidities, you're not going to work, you're staying at home, we're watching you very closely. But the other people, if you're young, if you're children, etc., we're sort of going to allow you to kind of go on with your daily life as long as you don't put at risk the people who are older. I think for that approach to work, you have to have the testing capacity to be able to really do contact tracing. To where when you get a case, you have to be able to do what South Korea does and really be able to figure out all the people that person interacted with and test all of those people and be identifying essentially all of your community cases to know whether a particular person has put your high-risk group at risk. I think that approach would work if we had better testing capacity and better contact tracing capacity, but we just don't have the testing capacity to do it right now.
And I think the other thing to add would be also depends on how much circulating the virus there is in your country or community. So I think what Dr. Khan is talking about with the contact tracing would be if there are very few cases, and then you can look at new cases and find the contacts. And if there's a lot of it in the community, then the horse is out of the barn already.
Right. And Sweden has significantly higher infection rates and death rates than Norway and Finland, with which it shares a border and do have lockdown. Another question, what is the performance of the test, the serology test, available at UCI?
There are 3 serology tests, well, two that are available, one that's nearing availability. The numbers vary, but we think that the specificity is somewhere in the 90s, and we think that the sensitivity is somewhere in the 80s in terms of performance. But a lot of it depends on kind of how you do the validation. And we've only validated internally on maybe 20 or so positive, 20 or so negative cases. So some other UCs have also done some validation. So we think that that's how well it performs, but there's some variability.
Here's a question asking whether saliva samples might be better than nasopharyngeal swabs for the detection of the virus, and there's a paper not yet in peer review on that.
So multiple papers have looked at different sampling sites and have found, well, the best is actually sputum, or if you're able to get a respiratory specimen, that's actually the best. But there's an infectious risk of trying to collect, have people cough into a cup who are contagious, that. So we generally don't do that. The best following that is to take both an oropharyngeal, which is kind of a throat swab, and the nasopharyngeal swab together. After that, nasopharyngeal, and after that, oropharyngeal. So now I haven't specifically looked at a study that took that saliva versus a throat swab, but I imagine the throat also has saliva in it. So if a nasopharyngeal works better than a throat swab, I would imagine it would work better than saliva.
Dr. McLennan was alluding to a study that we've heard about, but I think hasn't been peer reviewed, saying that sputum samples were a good source for testing. But again, we haven't seen that directly.
Sputum is a good source. Yes, sputum definitely. I think there's multiple studies on that.
Tony James asks, do you think the drugs would work best prophylactically? These are the, you know, the sort of Tamiflu type drugs, the ones, yeah.
Yeah, and so there was in the data that was presented internally from the remdesivir trial, there was some thought that the patients who got the drug earlier did better. And so, yeah, I think that some of the antivirals likely will have some prophylactic benefit. It's a very hard trial to do to prove that. You know, I guess I shouldn't say that. It's not hard, but it requires probably more people to do that, because, you know, you'd be treating people who where only a certain percentage of them would develop the disease. So you'd need a higher number to get statistical significance for a prophylaxis trial. So I do believe that that's going to be something in the future, but until we get that data, it's going to be a little while.
Dr. Khan, could you comment on convalescent serum?
Yeah, so in convalescent sera, it's been used for other respiratory viruses with very mixed success, or other viruses with very mixed success. You know, for Ebola, it didn't really work, although people say part of the reason it didn't work is because they didn't test for the amount of antibody in the sera. There's a clinical trial that's run out of Hopkins and Mayo that is looking at this for various indications. I think, to me, I'm a bit skeptical, just because you know, the experience with other viruses hasn't been entirely positive, and you know, most of the pathology occurs in the lung, and this is convalescent plasma you're injecting into the bloodstream, and so the antibodies will have to traffic to the lung. So I'm skeptical, but I do think it needs to be studied. So I would encourage, like, I think it's something we need to do clinical trials on. I don't think we should be doing like compassionate use, kind of like one-off, you know, treatments of patients, because we don't really learn anything from that. And, you know, we don't know if the patient got better because of the plasma or because of just that was their disease course. And so it really needs to be done in a clinical trial setting.
Sorry. Another question asked about what's known about the suggestion that the virus can have direct and significant effects on the vasculature.
It's, I guess, I don't know if Ming, you want to.
Yeah, I don't know that we know that much about the vasculature. Again, we know that there's a coagulopathy, as we mentioned, but on the vasculature, I don't think we know a lot about that. There have been reports in young kids of a Kawasaki-like disease with vasculitis, but these are brand new reports. But these are kids who present with fever and systemic illness.
Yeah, I actually looked those up, and it seemed like very few patients, and it was sort of unclear if how significant that finding was. I think more work needs to be done on that. But yeah, no, I mean, we think, yeah, there's a lot more is known about clotting than is known about vascular effects.
I think one thing that we should point out is that right now, just as with the testing, there's not a lot of regulatory review. There are a lot of articles which are being rushed to publication, a lot of articles that are released without peer review. And so you have to take everything with a grain of salt. There are some good studies, there are also some which are not so good. So we're in a bit of the Wild West here.
Yeah, and I'll particularly say the media, you know, isn't really capable of like distinguishing a good study from a bad study, is what I found in this environment. So, you know, I would be kind of skeptical. I mean, you know, I think most people in this audience are scientists, and you know, so you can go to the study and actually look at it and evaluate it. Unfortunately, I think most media reports I've seen haven't really been capable of that. Like they're looking for a headline more so than a rigorous analysis.
One question from Susanna Sandmeyer was, how much a limitation, and are we testing autopsy patients?
The free testing in LA, and I think LA County in general has been able to procure tests, and the you know, the state of California has been able to procure some PCR tests as well. So I mean, I don't know what exactly their supply chain is, but the PCR tests are more available now than they were in the past.
And what I read was that prior to this, you needed a doctor's prescription, and it was only for people who are symptomatic. But the latest report I read yesterday was that I think the mayor said that anyone could get it, and the details are you don't have to have symptoms. But the mechanics of how you get the testing, I don't know the details. But supposedly it's now available for everybody, and you don't have to pay for it.
Right. Let's see, any other questions here? I think that's it.
Okay. Thank you, everyone. Thank you, Dr. Khan, and thank you, Dr. McClelland. And if this goes on, we'll have another update in a few weeks or a month. All right. Thanks, everyone.
All right.
Thanks.